We all know why we should screen for cervical cancer. There are various screening methods available, namely cytology or Pap test, which has already been discussed in a previous module, both conventional cytology and liquid-based cytology, visual inspection with acetic acid, HPV DNA testing as a primary testing mode, and today I will be talking on co-testing with HPV DNA and Pap test. And if we have a positive HPV DNA or a Pap test, what are the triage tools to be used? And finally, I will be discussing the FOXI GCPR guidelines for cervical cancer using HPV DNA and Pap test. So, the clinical applications of HPV testing is either primary screening test alone or in combination with cytology, triaging women with abnormal Pap tests, which is reflex testing, and follow-up test for women treated with ablative or excisional procedures. Probably this is the best method to follow up patients who have been treated. And the co-testing rationale is the HPV DNA testing is more sensitive than cytology in detecting high-grade CIN, but if it is very sensitive, there can be more false positives. So, it is combined with cytology, which is very specific, and both the sensitive HPV DNA and the specific cytology test used together will determine further management. So, if you can see this slide, it is seen that cytology after a period of 6 years has a 0.97% of developing cancer. Primary HPV testing has a 0.27% chance of developing cancer after 6 years, but about 0.1% chance with cytology and HPV. So, out of the three, the co-testing modality is definitely better. However, the cost increases significantly, and therefore, people or organizations or countries are moving to primary HPV testing.